This video is the second part of achalasia. Do look into the previous video to learn from definition till clinical manifestations of this particular condition. I'm Sharon. I'm working as an associate professor at M College of Nursing. What are the objectives that we'll be addressing in this video with regard to the topic achalasia? Achalasia cardia is a rare chronic disorder. It is one of the esophageal motility disorders. It is defined as the absent or ineffective peristalsis of the distal esophagus, that is the lower two-thirds, accompanied by failure of the lower esophageal sphincter, LES, to relax in response to swallowing. Narrowing of the esophagus just above the stomach results in a gradually increasing dilatation of the esophagus in the upper chest. There can also be a selective loss of inhibitory neurons, resulting in unopposed contraction of the LES. Achalasia may progress slowly and occurs most often in people 40 years of age or older. Diagnosis of achalasia. The X-ray studies can show esophageal dilatation above the narrowing at the gastroesophageal junction, widened mediastinum, and absence of funnel gas shadow. Further, barium swallow, CT of the chest, and endoscopy may be used for diagnosis. Next, we are going to be looking at high resolution esophageal manometry, HRIM, with impedance testing. This is a diagnostic measure that measures the pressure and muscle contractions within the esophagus to assess its function. It is useful in diagnosing conditions such as achalasia, dysphagia, and GERD. This study can confirm achalasia in both children and adults, and thereby this is the gold standard. There are three types. Type 1, classic achalasia with failed peristalsis. Type 2, achalasia with pan-esophageal pressurization. Type 3, achalasia with esophageal spasm. You can see the pressure ranging from 0 to 150. Both type 2 and type 3 have the pressure ranges. Patient presents with dysphagia, the diagnosis of malignancy should always be in view. Other disorders in the differential include diffuse esophageal spasm, scleroderma, which is a common complication of systemic sclerosis, causing dysphagia, heartburn, and esophageal dysmotility due to collagen buildup in the esophageal muscle. Gastroesophageal reflux disease, stricture, Schatzky ring, which is a narrowing of the lower esophagus that can cause dysphagia. This narrowing is caused by a ring of mucosal tissue or muscular tissue. Hiatal hernia, otherwise referred to as diaphragmatic hernia, and paraesophageal hernia. The goals of treatment are to relieve dysphagia and regurgitation, improve esophageal emptying by disrupting the lower esophageal sphincter, and prevent development of megaesophagus, which is enlargement of the lower esophagus. Cases: instruct patient to eat semi-soft foods slowly and to drink fluids with meals and sleep with head elevated. Calcium channel blockers such as nifedipine, nitrates such as isosorbate dinitrate, and phosphodiesterase 5 inhibitors, example sildenafil, have been used to decrease esophageal pressure and improve swallowing. This is a temporary measure. It has to be taken sublingually 30 to 45 minutes before meals to improve dysphagia. The efficacy decreases after usage for a few months. Injection of botulinum toxin, Botox, into quadrants of the esophagus via endoscopy inhibits the contraction of smooth muscle. Periodic injections are required to maintain remission. This is used in older clients. Effect short term, that is 6 to 7 months. May be treated conservatively by pneumatic dilation by endoscopy to stretch the narrowed area of the esophagus. There is a high success rate for this procedure. It can be painful, therefore, moderate sedation in the form of an analgesic or tranquilizer or both is administered for the treatment. Perforation is a potential complication, whereas its incidence is low. The patient, therefore, is monitored for perforation. Abdominal tenderness and fever may indicate perforation. There is an increased risk of GERD post this procedure. The effects of balloon dilatation is short term, that is, for a period of 12 to 18 months. Therefore, recurrent dilatation may be necessary. The next procedure is POEMS, which is per-oral endoscopic myotomy, which is a minimally invasive procedure. Here, an incision is made in the mucosa a few centimeters before the lower esophageal sphincter. Through the submucosal plane, the LES is reached, incising smooth muscle to relieve tightness. The incision is then closed with clips and the patient is monitored with a swallow study before advancing their diet and returning home. May be treated surgically by esophagomyotomy, otherwise referred to as Heller myotomy. It is usually performed laparoscopically, either with a complete lower esophageal sphincter myotomy and an anti-reflux procedure, or without an anti-reflux procedure. The esophageal muscle fibers are separated to relieve the lower esophageal stricture. Patient can usually return to work in 1 to 2 weeks. Patient must remain upright for 1 to 2 hours after eating in order for gravity to aid in the entry of food into the stomach. The risk of puncture is less than 1% for this procedure. DOS fundoplication is a type of partial anti-reflux surgery where the upper part of the stomach, that is a fundus, is partially wrapped around the lower esophagus to strengthen the valve and prevent stomach acid from flowing back into the esophagus, thereby reducing GERD. Since this is done in addition to Heller's myotomy, this is referred to as Heller-Dohr procedure. It shows the pictorial representation of Heller-Dohr procedure. With regard to prognosis, the use of pneumatic dilatation and laparoscopic myotomy can produce good results with symptom relief. Rates of esophageal perforation are rare after pneumatic dilatation, but relapses frequent. The following are the complications of achalasia cardia: esophageal perforation, recurrence despite treatment, gastroesophageal reflux disease, bloating, and there is a potential cancer risk. The references for this condition. Thank you for watching this video.